This explainer is based on Autoimmune Inner Ear Disease, AIED, a vestibular physician's deep review, published by Australian Dizziness Clinics, available at australiandizzinessclinics.com.
Okay, let's dive right into this explainer. Autoimmune inner ear disease, or AIED, occupies a really unique, strategically critical niche for us as vestibular physicians and audiologists. It's rare, sure, but it is one of the very few causes of progressive cochleovestibular failure that is genuinely treatable. Today, we're going to explore the underlying immune mechanisms, the exact histopathology, and those absolutely crucial bedside red flags that should immediately trigger your clinical suspicion. To make sure we extract the highest yield clinical insights, here's our agenda. We'll look at the loss of immunological tolerance, the 4 mechanisms of injury, the histopathological cascade, clinical bedside red flags, systemic autoimmune associations, and finally, key clinical takeaways. Let's get right into it.
Section 1. Loss of immunological tolerance. To truly grasp the pathophysiology here, we first need to establish exactly how the inner ear's baseline protective system gets disrupted.
You see, the inner ear is not, as we once thought, absolutely immune privileged. You can think of it sort of like an exclusive VIP room. It's sequestered behind a protective blood labyrinth barrier, which is a tight-junctioned analog of the blood-brain barrier, but it still retains its own internal security. The endolymphatic sac actually acts as the localized immunological hub of the labyrinth, fully capable of antigen uptake and processing.
So what exactly goes wrong? Well, the central event in AIED is the breakdown of this barrier and the subsequent loss of immunological tolerance. This breakdown is often facilitated by resident cochlear macrophages. These are specifically identified by IBA1 expression, and they populate the cochlea constitutively, proliferating rapidly after an insult. They basically provide the antigen-presenting and cytokine-releasing substrate that ignites an autoimmune reaction against the body's own, normally sequestered, inner ear antigens.
Section 2. 4 mechanisms of injury. Let's move to the complication phase and see how exactly this protective system fails. The literature points us to 4 proposed non-exclusive mechanisms. These 4 mechanisms really help explain the clinical variability we see with this disease. First up, we have molecular mimicry. This is where an environmental trigger, most often a viral infection, generates antigens that are structurally similar to inner ear proteins. This causes cross-reactive antibodies to mistakenly attack the labyrinth, which perfectly explains that post-viral onset we often see. Then, we have bystander activation, hidden antigen exposure, and direct CD4-positive T-cell-mediated injury.
In bystander activation, a primary insult, like an infection, trauma, ischemia, or honestly even severe noise, breaches the blood labyrinth barrier. This breach releases pro-inflammatory cytokines, specifically interleukin-1 or IL-1 and tumor necrosis factor alpha or TNF-alpha. This non-specifically amplifies a localized immune response. It beautifully explains why AIED so frequently follows what seems like a completely trivial precipitant.
Now, this barrier disruption leads us directly into the 3rd mechanism, hidden antigen exposure. By breaking that barrier, you're exposing a totally naive immune system to normally sequestered inner ear proteins. Suddenly, proteins like cochlin, heat shock protein 70, and type 2 collagen are revealed. This prompts the production of detectable autoantibodies that form immune complexes and fix complement, which directly damages the stria vascularis and our hair cells.
And this brings us to a brilliant illustration of the cell-mediated component. Solaris's pivotal 2004 murine model proved that CD4-positive T cells, specific to the inner ear, can directly transfer autoimmune hearing loss. This is huge because it means we aren't just dealing with a purely antibody-driven process. Cell-mediated attacks are directly pathogenic. Ultimately, both the humoral and cell-mediated arms are contributing to the labyrinth's destruction.
Section 3. The histopathological cascade. Having established these specific cellular mechanisms, mimicry, bystander activation, hidden antigens, and T-cell attacks, we now need to look at how these elements actually combine to damage the labyrinth.
Following this cascade essentially maps out the exact final common pathway. It traces the sequence right from that initial trigger, reaching the barrier, to macrophage activation, down to autoantibody production and CD4-positive T-cell recruitment. This leads straight to complement activation and major cytokine release, cascading all the way down to complete cochleovestibular failure.
The resulting histopathology is frankly devastating. Immune complexes and aggressive cytokine networks drive heavy lymphocytic infiltration.
We start seeing fibrosis and new bone formation within the cochlear duct, along with severe atrophy of the stria vascularis and obliterative microvasculitis of the labyrinthine microvasculature. All of these incredibly destructive processes ultimately converge on one thing: irreversible hair cell loss.
Section 4. Clinical bedside red flags. Because we don't have a single pathognomonic test for AIED, clinical suspicion is absolutely everything. How do these unseen microscopic events translate into tangible red flags when a patient actually walks into your clinic? The single most useful discriminator you have is disease tempo. Sensorineural hearing loss, or SNHL, associated with AID progresses rapidly over weeks to months. It's too fast for presbycusis, or most genetic losses, which usually take years, yet it's way too slow for the abrupt, hours-long deficit of idiopathic sudden SNHL or vestibular neuritis. If the timeline is weeks to months, AID absolutely must be at the very top of your differential. When looking at the fluctuating thresholds here, the loss is characteristically bilateral, progressive, and fluctuating. Now, the disease might begin unilaterally, but established bilaterality, which is frequently asymmetric, is the rule. Furthermore, early thresholds characteristically fluctuate, and you'll often see a well-documented partial recovery after a dedicated trial of corticosteroids.
Now, whatever you do, don't ignore the vestibular side of things. Vestibular involvement is reported in up to half of all these patients. Because the immune injury tends to be bilateral and indolent, the vestibular phenotype typically presents as chronic bilateral hypofunction with oscillopsia. It closely resembles a progressive bilateral vestibulopathy rather than the distinct discrete attacks you'd expect to see in Meniere's disease. And keep in mind, subclinical vestibular involvement is actually way more common than the patient's symptom history might suggest.
Section 5. Systemic autoimmune associations. Because the inner ear attack is frequently just one part of a much broader systemic loss of self-tolerance, we absolutely must look beyond the ear. AIED should really be conceived as the audiovestibular expression of a broader immune dysregulation.
Roughly 1/3 of your AIED patients have or will eventually develop systemic autoimmunity. This makes it absolutely mandatory to actively screen for conditions like Cogan's syndrome, which, by the way, is a not-to-be-missed cause of severe deafness and interstitial keratitis in young adults. You also need to screen for systemic lupus erythematosus, ANCA-associated vasculitis, and rheumatoid disease. The audiovestibular system can literally be the sentinel presentation for these major systemic conditions.
Section 6. Key clinical takeaways. Let's distill all of these dense pathophysiological insights and clinical presentations down into our key, actionable takeaways for your everyday practice. First, the final common pathway is immune-mediated injury involving a barrier breach, microvasculitis, and ultimate hair cell loss. Second, both the humoral and cell-mediated arms strongly contribute to this destruction, with interleukin-1 emerging as a highly targetable effector. And finally, the presence of these red flags, specifically that bilateral weeks to months progressive hearing loss, demands that you actively screen every single patient for systemic autoimmune disease.
In the next explainer, we'll cover the rigorous diagnostic criteria and exactly how to implement the therapeutic steroid trial. Visit AustralianDizzinessClinics.com for the full clinical review, clinician cheat sheets, and companion materials. As we wrap up this topic, consider this provocative thought. Could the exact keys to reversing unexplained progressive hearing loss be hiding in plain sight, right within the cytokine networks of our own innate immune system?